Okay. Well, welcome everyone to a very special Grand Rounds. This is the annual Britell Lectureship. And so as a reminder and a memoriam for Bob Britell, who this is in honor of, Bob was one of the very early faculty members in the Department of Medicine at a time when the total number of our department faculty was less than 20. So when Gordon Micklejohn came and started the department, he started small. Dr. Britell was a general internist who he recruited out of private practice. Dr. Britell had a couple of very key roles in a leadership position from in terms of the department. So he actually was the founding chair of the Department of Family Medicine as a general internist. So at the time, family medicine was emerging as a subspecialty. And Dr. Micklejohn wanted the School of Medicine to have a department of family medicine, and so it was actually created within the department. Dr. Britell was the original chair until he recruited his own replacement and launched the department. The same was true of the Division of General Internal Medicine. So academic, so if you prior to the mid-60s, almost all internists were general internists, and those who were subspecialists just developed expertise. And so that was the tradition that Dr. Britell came through, though he stayed a generalist. But the idea of having an academic GIM division was emerging, and University of Colorado was one of the first, and Dr. Britell was instrumental in founding that. But the thread throughout it all was his role as an educator. So he was a very committed educator. It was the thing about his role that attracted him to an academic position and was what he loved the most. And so when he passed away, his family created an endowment, which enables us every year to recruit a thought leader from around the country to come and speak to us on some topic relative to education. So this year, we're delighted to have Dr. Addie McClintock, who Steve Fust is going to introduce.
Thanks, Mark. We're really excited to have Dr. McClintock talk to us today about psychological safety in the clinical learning environment, and then tomorrow speaking at departmental grand rounds. Dr. McClintock attended Middlebury College for undergrad, medical school at NYU, and did residency at the University of Washington. Dr. McClintock's an associate professor of medicine, still at the University of Washington. She is a primary care clinician in the Women's Healthcare Center, where she provides management of chronic disease, outpatient gynecologic conditions, and provides family planning services. She's also the director of the Teaching Scholars Program for the School of Medicine and the founder of the Women's Health Training Pathway for the Internal Medicine Residency. Her scholarly work is focused on the psychological safety and learning climate for medical education. So please join me in welcoming Dr. McClintock.
Thank you, everybody, for coming. Good morning. I will just get started. Let's see here. I think I can use this. Nope. I'll just use this. Okay. Sorry. All right. There we go. Okay. No financial disclosures. Very exciting first slide. So every talk has to have some learning objectives. Here are ours. I hope that by the end of the talk, you will recognize the importance of the learning climate in optimizing trainee learning, sense of belonging, and well-being. Apply continual, deliberate self-reflection to improve the learning climate, and identify and employ actions, words, and behaviors that positively impact the learning climate. But I want to start by just asking you to reflect on a time when you had either a positive or a negative learning experience during your training. And I'll give you like 15 seconds because I want to think about what comes first. Okay, raise your hand if something positive came to you first. Okay, we have one hand in the room. Two. Raise your hand if something negative came to you first. Okay, if everyone else in the room, and I can't see Zoom, but I'm going to assume we have a relatively similar ratio. So usually it is the negative that comes to you first, and your brain is kind of evolutionarily designed to do that. You have a very efficient, effective threat detection system that works to create a very quick route to those memories to keep you safe. That makes sense. So even if the majority of your experiences were overall positive, you are more likely to keep those negative experiences at the forefront of your interactions. Now, just for a second, I want you to then consider, what was the role of the supervising team members in that moment? Because ultimately it is the supervisors that tend to set the tone and the culture for our teams. And I'm going to argue that they are responsible in many ways for building that positive team culture that's conveyed through the interpersonal interactions that you probably just sort of called upon. Okay, so here's our roadmap. We're going to talk a little bit about definitions, why psychological safety matters, how to do it, and how it works. So first, definitions. You might hear words like learning climate, learning environment, and what I'm going to argue is that the learning environment is really mostly about the physical spaces around you, but the learning climate is about the experience of being in that space. So for example, I could be in the desert. I could be hot, I could be sweaty, I could be thirsty, I could be alone and freaked out. Or I could be in the desert and I could have water, I could have food, I could have a guide, a map, and I know exactly where I'm going. And being in those two spaces, being in that same physical space can have a completely different feeling of being there. And psychological safety, then, is the belief that one will not be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes. And I want to highlight again, just like with climate, it's an internal experience and it's an internal belief that one will not be punished or humiliated. And so it's fundamentally an interpersonal phenomenon that exists at sort of the level of a team. But I do also think organizations can play a role in terms of defining what are the cultural norms of your smaller team units. And I also think it's a culture we choose to create. We can choose, especially as leaders, how we respond to the things that happen, how we convey things about this is just how it's done around here through our actions and our behaviors. And so it is something that we choose. We have almost like a cultural agreement about what is normal and what is not normal in our individual settings. And we can also choose to change that cultural agreement if we think that it is really not serving us anymore. I like to address a couple common sort of beliefs about psychological safety. Number one, it's not just being nice. It's really not about that at all. There is certainly a component of warmth and acceptance, but it's not just being agreeable or not saying anything mean, not giving constructive feedback. It's really about an absence of judgment. And even more than that, because we are all making judgments, decisions all the time, but it's really about an absence of fear or shame or retaliation because of that judgment that someone might be making. It's also not the default. Just coming together as a team does not guarantee psychological safety. It does not simply exist when groups of people come together for work or education. And as humans, we're typically actually pretty risk averse in the sense that we like to default to managing our image, protect our status, and avoid taking social risk or being wrong. So when you become part of a new team, it's best to assume that the psychological safety for members is not yet present and needs to be cultivated. And then it forms quickly. So although it's not a binary like present, not present, there really are more gradations in there, but there is still this idea that people, especially trainees, need to sort of make a decision about what type of environment they're in pretty quickly because it matters. It matters because they're always being evaluated. It matters because that matters for their future, like career opportunities. They have to know pretty quickly what their sort of affordances are in any given environment. And it's not achievable for all. I think it's important to recognize that these are what I'm going to talk about. I would describe them as more like universal precautions. There are some people who in our spaces, this will never be achievable. And I think we need to recognize that. But at the same time, it's still absolutely worth trying and doing these bare minimum things, which will improve the environment to some degree for most people on a team. Okay, so why does it matter? The largest drop in the perception of the clinical learning environment or in learning climate occurs in the transition to clinical trainings, and it's 3 times greater than the drop between the first and the second year. So this is a significant change that people perceive almost as soon as they enter our clinical spaces. But even before they enter our clinical spaces, this is a different study looking at students who, this was 14,000 medical students from 140 US medical schools, whether they experienced mistreatment in year 2, before year 2, or in year 2, never, once, or more than once, and then some other measures about how they were doing at year 4. So whether they experienced mistreatment never, once, or more than once, had higher rates of exhaustion in year 4, disengagement in year 4, and career choice regret in year 4. And all of this is before they even come to us. And all of these differences are significant. And I think you can also see here like a dose response. Okay, different study looking at attrition from medical school. So again, whether somebody had experienced mistreatment or discrimination never, an isolated time, or recurrent, and what their odds of attrition were. And what I want to show you also is that whether or not they experienced it one time or recurrent was not statistically different from each other. So one time can have a huge impact on whether somebody chooses to remain in medical school or not. And important to recognize that different groups have a disparate amount of sort of how much this impacts them and how much attrition we see from medical school. So those who are underrepresented in medicine have some of the highest rates. Again, you can see for almost everybody this sort of dose response curve happening there as well. So we really start to work against some of our larger goals in medicine around creating a diverse and thriving workforce if we are not able to sort of make some movement and improvement in our learning climates. Here's some other things that students say about what unsafe climates mean for them. So inefficient learning. Students describe things like, well, I had a question, but I didn't ask it. I just went home and read because I was afraid to ask it. And so, yes, of course, we want them to go home and read, but they already spent the first 2 years reading. They missed the opportunity at the point of most relevance to ask an expert a nuanced question to understand something deeper. A really high cognitive load. They describe spending 20 minutes crafting a question to look smart that they already know the answer to. And it's extremely distracting for people to be spending their cognitive energy doing that when they're actually supposed to be spending their cognitive energy doing this. And so they really miss the ability to focus and pay attention. They tend to start to focus much more on grading and image, and it starts to be learning really motivated by image. So just to sort of look good and get a good grade. And then a withdrawal and trying to hide, like I just put my head down, just try to get through it. And I think I certainly can recall times like that in my own training. What does that mean for us? Missed teaching opportunity. Trainees are distracted and they can't focus on learning. They don't ask for help, and then you don't know the knowledge of their skills and their limits, and they can become disengaged. Okay, enough with the depressing. What can you get back from psychological safety? What are some of the benefits? So some of the benefits specifically for medical trainees include learning, things I already sort of alluded to, reduces their cognitive load, allows them to focus on learning, creates an openness to disclosing gaps and needed support, builds agency and engagement in the work, of feeling like they're have some say in what's happening, and belonging, that the belief that their role in the work is meaningful and that their contribution is valued. It also has a big role in equity and assessment. And the reason for that, one of the reasons for that, is because people have the brain space to fully participate in both the learning and the performance. So if we only have X amount of brain space and it's taken over by a ticker tape of stereotype threat and all these other things that are happening, they no longer have the opportunity to show and use all of their cognitive resources that other students might. And then safe supervision. So when psychological safety is low, students, as I mentioned, tend to focus on evaluation and grading. They will have a significant fear of failure, fear of revealing a deficit or saying the wrong thing. And as a result, their knowledge will be obscured, their gaps will be obscured, and you risk an inaccurate evaluation of what they're capable of and how to best supervise, providing the right amount of supervision. Similarly, when they can focus on growth and learning and psychological safety is high, they are more likely to focus their effort on gaining knowledge and skills. They will ask for help, they will disclose their gaps, and then number one, what you can teach them. You have an accurate assessment of like where they are and what they could learn next, and you can provide the correct amount of safe supervision that they need. Okay, how to do it. So the first thing I just want to say is, generally speaking, these two studies were before we started to do some of our studies, and these qualities that I'm going to describe came from studies where they created something that they expected to be a safe environment. Then they sort of asked them, like, was that safe? And then they asked them why. So these were some of the things that students said. Continuity, high quality interpersonal relationships, a friendly, welcoming environment, a flexible learning agenda, flattened status structure, lack of formal assessment and time for debriefing. Does this sound like the medical school you went to? No, right? The very premise and like point of third year is frequent rotation for broad exposure. And that absolutely has a value and a purpose, but it's not going to create these high quality interpersonal relationships. A friendly, welcoming environment, sure, great. Flexible learning agenda, this one comes a little bit more from a classroom or setting, so is a little bit harder to sort of apply in clinical settings in the sense that our learning agenda is flexible to whatever we're seeing right then. So maybe that one is doable. A flattened status structure, generally not. We're pretty well wedded to our hierarchy in medicine. Lack of formal assessment. There's almost no places for medical students where assessment and learning are decoupled. Almost every single place where they are learning, they are also being assessed at the same time. And then time for debriefing as a group. Sure, yes, would be great. We are super, super busy on our teams and our wards. And I think this is one we are doing better at in general because there is such an emphasis on debriefing from the perspective of quality improvement. But I think still these are very difficult. So what I like to just sort of highlight here is that basically the design of medical education is such that it is designed structurally to withhold psychological safety. All of these things are nearly impossible or do not exist. The only one you kind of have some control over is a friendly, welcoming environment. And again, like I said, psychological safety is not just being nice, but there is something about the way that you set up your spaces to be welcoming and to encourage people, express happiness to have them there that can be really meaningful to people. This was a different study looking at what in the literature is already out there from sort of a medical education perspective or just medicine more broadly speaking about different behaviors at different levels of an organization that can promote psychological safety. And like I mentioned earlier, it's considered a team level phenomenon. So usually it's the team leadership of a given wards team, for example, that sort of sets that stage. But there is also the interpersonal, which is really what sort of conveys meaning to people. And I think when we think about the role of culture, it is often really created by these sort of larger organizational norms. As I mentioned, like what can you expect as a leader to have time for, to be rewarded for, to be punished for? And so I think it does matter as well at the organizational level, what is sort of happening, even if it's really technically the team level where this exists. And then the individual, so you may recognize this as sort of the social ecological model, but we kind of pulled out the individual from this because I do think there's some way in which the individual and their environment can interact and sort of act on each other. So I'm just kind of going to go through each level of this and describe what we know about how to create psychological safety or what promotes psychological safety at these different levels. So in the interpersonal level, The person who popularized the term psychological safety was named Amy Edmondson, and she's an organizational psychologist at Harvard. And so she describes what she calls 3 leadership tasks that promote psychological safety. And those tasks are set the stage, invite participation, and respond productively. And her description of these tasks are setting expectations and defining common goals, often includes also sort of like a description of how interconnected and complex our work is and the need to sort of work together. Seeking input, listening to the input that you asked for, modeling humility when you can. And responding productively is really about acknowledging the work that people do, thanking them, providing growth-oriented and sort of future-focused feedback, and then reestablishing safety when it's threatened, which sort of means, for example, if you've set up everything wonderful, you feel like the team's going really well, then your resident says something really mean to your med student, it's your job as the team leader to say to that resident, that's not acceptable behavior, that's not how we operate on this team or how I want my team to be, and you have to reestablish that safety. If you remain silent, it sends the message that this is okay. So there is a role about reestablishing safety when it is threatened that's pretty important. Okay. From the medical education and clinical learning perspective, here are some of the things we hear students talk about as being meaningful to create psychological safety. So number 1, a learning focus. Supervisors explicitly tie certain behaviors, like asking questions using a Socratic method, for example, to an underlying goal of learning. They give students very clear expectations, make it clear what they can do, what they should do, what they cannot do, how much work is expected, what type of work is expected, and then learning objectives for their time together, which it's always better if we can help a student come up with their own, but there's oftentimes we know best what our specific environments are most well suited to teach or what we're really good at teaching, and so we might shape and mold a little bit in that way. Acknowledgement, greet them by name, introduce yourself, express happiness to have them there. And I want to highlight here that to students, this was so meaningful. In my mind, it's so simple. And there are so many places where it is still not happening. Invite participation has several different sort of ways that appears, but a relationship, getting to know them as a person, demonstrating an interest in them, enthusiasm for teaching, an investment in their learning, and identifying shared interests, which I want to put a little asterisk on that one, because I do think that while it is important to identify shared interests, we want to be mindful that if that's the case, we're doing that for everybody on the team. What can sometimes happen is like, oh, these members of the team love the Seahawks, but this one doesn't know anything about football, and now they're kind of left out and feeling excluded, even though the intent was really to create connection. Humility, talking about we're all learning together, and I'm going to talk a little bit more about that towards the end as well. And then supported autonomy supports inclusion in the work, a sense of purpose on the team, and it demonstrates that we have trust and confidence in them and their capabilities, and that we're here if they need help. Feedback, specific, clear, timely, well-timed. As I'm sure you all know, you could have an entire day on feedback. I've got one tiny little point, but I think the main issue really is about being specific to the person, and that it demonstrates that you're paying attention, that you're watching, that you're invested. And it doesn't need to be like, you're doing great, positive feedback only. What actually really matters is more that there's a relationship and a connection taking place, that sort of the feedback is situated within that. A re-emphasis on learning when failures occur, keeping in mind that for a student, so many of these small things that may go honestly even unnoticed by us can be huge points of stress, like being put on the spot on rounds and they don't know the answer. Acknowledging and thanking every people on the team for the work and the effort that they put in. When wrong answers happen, find that golden nugget of truth, no matter how small, and sort of help them work from there. Unsafe things, students describe team members seem annoyed, which is basically like they're not paying attention when you talk, their body language is they're on their phone, short answers, other ways of sort of conveying even non-verbally that people are not that interested in sort of engaging with you. Non-specific feedback. As I mentioned, feels often like they're not paying attention, they don't care, they're just sort of like checking a box. Deriding fund of knowledge, so things like a third-year student really should know that can make an environment feel pretty unsafe. Observing mean, rude, or unkind behaviors to others. This one's really interesting because sometimes students describe like, well, the attending was really nice to me, but then they were not very nice to the residents. And that to the student does not actually make a safe environment because there's a fear about sort of, well, what are they saying when I'm not around? And then there's a secondary issue of like, well, maybe this favor that I have is very fragile. And so it continues to be a place where you're sort of walking on eggshells and you're not really sure. Observing and then no autonomy or exclusion from hands-on works tends to send the message like, I don't trust you to do that. Your presence here is not meaningful in terms of the care, and so can make people feel pretty unsafe. Okay, what about specifically the team leaders? And as I mentioned, this is where we set up and talk about cultural norms. So patient care and learning as core goals, coaching-oriented leadership and teaching, perceived organizational support for work-life balance, a team leader's love of the profession. In the context of simulation, a really explicit social contract for respect, allyship, and maintaining the fiction contract, which if you haven't heard, that basically is like, we're all gonna pretend that this dummy is actually a live person. Challenging team members in respectful ways, and then if that's not happening, sort of like I said, reestablishing those ground rules if that's not the case. And then an invitation and appreciation for others' contributions. As I mentioned, at the organizational level of sort of, you can think of this as your institution, you can think of this as healthcare education system, but you can sort of still work to create certain conditions that educators can work and learn in that will sort of facilitate or make more difficult the ability to create psychological safety. So for example, do teams have time allotted for team formation, getting to know each other on the first day of service together, trying to create as best we can longitudinal designs for teaching settings, providing protected time for things like debriefing, like I mentioned, offering learning settings that are informal and also learning spaces that are not tied to formal assessment. And then thinking about how as leadership do we implement and sort of sustain and support the predictability of those practices. So remove competing factors, remove distractions, protect that time, remove interruptions. Using near peer coaching and faculty development can be helpful. Creating communities of practice. One of the things that's really interesting or sort of like an unintended consequence of these medical centers like here, where you have super specialized care, the more specialized a person becomes, the smaller their community of practice. So the more we have to really work to kind of cultivate that community with those around them if they're in a very small specialized space. And then similar to other places, perceived a larger organizational support for work-life balance. And then of course, doing things like this, inviting me to teach faculty about things, what are the specific skills that can optimize the climate. So check done, good job. Okay, how are decisions about safety made? So they are made at the level of an individual. It's an individual who decides whether or not the space is safe for them. And there are aspects of that in terms of how they interpret events, what beliefs they have about themselves, what beliefs they have about the people and the structures around them. But then there's also really a powerful component of what they observe and experience in the environments and their prior experiences with education, their prior experiences in terms of confidence, their perception of the stakes of the situation can all impact their decision. Other factors include things like just sort of where within the hierarchy or where within culturally privileged you might be. So for example, gender might be one. Physical attributes, things like being tall, being white, being a male, tend to create people in positions who rate their psychological safety a little bit better or higher. Learner stages, comfort with uncertainty, which I think is interesting because we see very often that early trainees may not be as comfortable with uncertainty, whereas we have sort of seen and recognized that uncertainty is something that's just part of our job. And then an individual person's coping strategies and their anticipated response from a supervisor about what might be, it's like a negative response depending on what it is that they're going to say or do. And then being formally evaluated, as I mentioned, will always sort of create some amount of impairment of the safety for most people. And then what we also hear, which is not surprising, but first impressions are strong, long, and built upon. So people will, again, they have to make those decisions pretty quickly. And while I said earlier, it's not a binary like safe, not safe, there really are gradations in what people sort of make their determination in terms of what I said, like the affordances of an individual environment may be, but they still do make those decisions pretty quickly, and they're pretty durable. And I think probably we can all think of a time where there was a team and it was such a great team and something kind of bad did happen, but like it didn't really hugely impair the safety of what the team, of the group. Conversely, there's times where things start out not so good, and it's pretty hard to repair that. It's pretty hard to build a better environment from something that started off not so good. It takes like a way even bigger intentional effort. When repair is needed, it is possible, but it's rare. Most commonly, it's just sort of those humanizing things of saying, I'm sorry, like, oh, I'm sorry I was short or rude or distracted this morning. I had something else going on. It's those moments of humanness that make us more whole as a person and help people see like it's not personal. I've got this other thing going on. And then they can sort of incorporate that. And that is one of the few things that I think can really repair. And the last thing I want to talk about doesn't fit really in any one category, but these ideas around power and hierarchy. When you talk to students, almost many comments that they say are sort of things like, well, I can understand why they would do that given that I'm a medical student. And so they are well aware of their position in the hierarchy, and they have bought into the idea that like because of that low position, it's okay to treat them poorly. I think that hierarchy has a role. Not everyone is going to agree with me that there are some problems, but what happens is that the structure of a team, which is meant to ensure safety and being able to make quick decisions with short amount of time and helping someone with the most experience be the leader and frankly legally responsible for what happens. But what happens, unfortunately, is that has also in many ways turned into a system of disparate social worth. It's really hard to separate those places where hierarchy is working in the medical side, but then go to lunch with the student and have a totally different relationship with them in terms of the power structure. And can you think of anywhere else in your life where you would refer to somebody by their role rather than their name? Like, oh, medical student, our medical student will do this, our medical student will do that. Like, I would never say, I actually one time had to say I couldn't remember the name of a partner of my patient, and he was exiting the room, and I said, excuse me, partner, I have a question. And I was like, that is the most awkward way to refer to someone. I would never do that in any other place. So we really do need to think about like, how are we addressing people? Can we separate this? We absolutely need team structure. We need that structure 100%, but we don't need the disparate social worth that has become attached to that structure. And we need a way to sort of separate those and remind ourselves medical students have names. They would like to be addressed by them. That is not a big ask. Okay, so then I like to just think a little bit about what are some other theories or things we know from either other disciplines that sort of add to this or give a little bit more credit or explain some of these things. So the first one I want to talk about is the concept of a meta message. So a message is the meaning of the words that come out of my mouth. The meta message is the larger message derived from what we say, how we say it, and the context we say it in. So for example, I could say to you, hi, it's so good to see you. Or I could say, hi, it's so good to see you. And you would immediately appreciate a difference in those two sentiments. And this is what medical students are doing. They are taking our words and they have to decide so quickly, well, what is the meaning of that? How do I interpret that? What does that mean I should do, shouldn't do? And they are using those messages and decoding them very quickly. And we do this in all parts of our lives, but it is, again, like especially critical for students to be able to do this. Some people have sometimes asked me, how is this the same or different than the hidden curriculum? And what I think is that these meta messages are how we are teaching the hidden curriculum. These are the ways that we are teaching that curriculum. So I'll just give some examples. Interrupting. What is the meta messages there? I know, it's perfect timing. What would be the meta message? Yeah. Thank you. Almost exactly. I don't think what you have to say is very important. How about this one? Yes. Oh, you also got my words almost exactly. I don't trust you. How about this one? Say it. Yeah, or looking good is more important than learning. Okay. These ones are a little more positive, even though they're a little more wordy. I give lots of feedback to everyone on the team. The feedback I give is to support growth towards independence for learners at every level. My main goal is for everyone to learn as much as possible and enjoy their time here, even if you aren't going into internal medicine. I just want to help you be the best that you can. You go first. If needed, I can add some tips based on what other cases I've seen. I trust you, and I'm here to help you when you need it. Can you tell me more about how you chose Y intervention? Show me what you know, and we'll work on that. Now, one of my colleagues said to me, can't you just say what's in the purple circle instead? And I was like, yes, you can. Really, the goal of this is to think about whatever words are most natural to you, make the most sense in your environment. But the message, if you're not going to use the purple circles, which you can, making sure that your message is aligned with that. Okay, how does psychological safety promote better learning? So if we think about our limbic system and our learning and our memory, I'm going to just try not to traumatize anybody, but talk a little bit about some of these different structures and how they are impacting memory, threat, and learning. So we have our reticular activating system. That's like our attention getter. It's our watcher for signals that are coming in. We have our hippocampus related to memory. The thalamus is kind of our relay station. And then we have our neocortex, which is where we do our higher order thinking, and our amygdala, which you can think of as our guard dog. So when you are in a place of safety, you can use what's called the slow pathway. Information comes in, goes to your relay station, has the ability to go to your neocortex, higher order thinking, linking it to things you already know, encoding that memory, and then it can leave. If you are under threat, comes in, goes to the relay station, brain's like, nope, no prefrontal cortex for you, to the amygdala, and back out. So people can make very powerful emotional memories in these situations, but they don't actually tend to learn. So when we think about some of these like shame-based teaching methods that many of us were taught using, it's not actually the way to promote learning. You will be surprised to hear. but really it's about, you are actually creating a space where people cannot learn. They cannot keep the information. And I would argue many times if we think back to what some of those experiences were, I personally can very often remember like the exact, like who was sitting where and what they were saying and doing. I could not for a million years tell you what the medical piece of information was that I was supposed to be remembering at that point. Okay, how does it support engagement? So here we can look to self-determination theory and think about, so self-determination theory talks about what are some core human psychological needs that promote learning, motivation, and engagement. And many of the tasks of psychological safety ultimately can sort of map to one of these. So autonomy in this setting is not as much about independence, the way we think of it in medicine. It's more about a feeling of internal locus of control. Like I have some control over what I do, what I'm allowed to do. And there's sort of an idea of support, that support. and choice in what students can do. Competence, I think, does have to do with the ability of like letting students participate, letting students see that they are competent, letting them notice that they're growing in their competence through some of these things that we are doing. And then relatedness really is about building that connection within your team, seeing them as a whole person, taking in what they have to say, and using that feedback within your whole team. So ultimately, many of the things that we talked about that sort of create psychological safety can map to and sort of build on creating a space where people are sort of meeting their core needs in terms of self-determination. Okay, the last one is, how does psychological safety support belonging? And I want to talk quickly about an intervention called the social belonging intervention, which was basically an intervention using storytelling. So they would have students come to a lab, they would have them read some information about students who were telling about how it was difficult to adjust to college, but then things were fine and I realized, I do belong, and it was made up data. And then they had students write a story, something short, about a time that they had that transformation about feeling belonging in any part of their life or related to school. And they had them videotape it. And they were told that this videotape is for another student. So they were basically told, like, you are a benefactor. They were not really under the impression that they were benefiting from anything. They thought they were like doing a kind deed to someone else. And the crux of all of these stories was the idea that things that are the adversity and the challenge that you're experiencing in this transition to higher education is shared by all students. It's short-lived, and it's not due to a fixed deficit related to you or to your ethnic group. So concerns about whether or not you belong were sort of presented as temporary due to the challenging nature of college and nothing to do with you individually. And there were a couple really amazing things that they saw with this intervention. So first of all, it closed gaps in GPA between European American students and Black and African American students. And I'm just gonna, I don't know if this pointer shows up. Yeah, I'm just gonna sort of highlight right here. These are the African American students who received the intervention. These are the African American students who did not receive the intervention. And these are the European American students who did receive the intervention, and you can see those GPA gaps closing over time. I will acknowledge that the European American students who received the intervention sort of continued to climb even beyond that. It also improved their self-assessed general health and other sort of more objective measures of health and their subjective happiness. And I'm including these graphs because I do think that the images of the difference is pretty powerful. So you have the randomized group and the social belonging treatment group. And you can see, so their self-assessed general health was significantly better. They asked them how many doctor's visits they'd had in the previous month towards the end of the study, and they had a significantly less visits. And then they rated their subjective happiness as better. So I want you to guess, how long was the intervention that students had to do in the first part of the study? How long did that take? You are more optimistic than I am, but good. But it's short, 1 hour. It took 1 hour. And when they did surveys for their senior year, it indicated that the students had absolutely no awareness of the intervention's impact. Like, they didn't see that intervention as having played a role. So I think our moments of humility, when we say, I don't know, when we model how we got to where we are and how long it took, are the moments of like microdosing that social belonging intervention. We are giving people these tiny little tidbits to say, just because you don't know something doesn't mean you don't belong here. I didn't know all kinds of things when I was in your position. And it takes work to get here. Everybody who's here, who's supervising, who looks like they know everything, took many years of hard work to get there. And so if you find that you need hard work to get where you want to go, that's normal. You're not doing it wrong. That is the expected process. And it's, I think, hugely impactful for people. So what I want to say as a wrap up is, what can you do? Show students that you care, that you care about them, that you care about their development, that you care about having them in your space, that you want to know them, where they're going, build connection. Show them that you believe in them, that you know they can get to the places they want to go, and that you're here to help them do it. And remind them that we are all here to learn. This is how we can show them that this is an expected part of the process and that everybody belongs here. How are we doing on time? Good? 15 minutes? Okay. So our food for thought then for today is I just want you to think about, what will you take from today? What will you do? If you will do anything differently, what will it be? And think just a little bit about some of the things and how they might apply to you and how you might want to create change in your environment. And that's all I have. I can take questions. And I put this here. We collect peer teaching evaluations if you are interested in being so kind. And then I'll take questions.
Really a wonderful talk. So thank you so much, Dr. McClintock. People on Zoom, please go ahead, put questions into the chat. People in the audience, raise your hand and I'll come around to you. And I'll start out with my question. So with what you were talking about with psychological safety, some of the questions and quotes that you were putting in there throughout, I was seeing a lot of overlap with intelligence mindset, growth mindset, fixed mindset. Though these are two different things. Could you talk if there's anything known about the relationship between growth mindset and psychological safety?
Let's see. I haven't looked at anything specifically relating those two, but I mean, overall, yes, 100%. The idea that there's growth-oriented feedback is most likely informed by the growth mindset literature from Carol Dweck. I think that we as educators can model a growth mindset, and that is hugely helpful to people, though that is how we create some of those moments of humility. And when we sort of do our best to teach from a place of growth and valuing that growth, I think we can sort of then create those spaces for trainees to also cultivate their growth mindset. Because we are not necessarily, you might already know, and Tyra definitely knows, but we are not even fixed in our fixed mindset. And many people can be one or another in different parts of even their own life. And the more growth and process-oriented feedback that we give people, the more we sort of push them to a place of growth if they're not already there. And so I think those tasks become basically the same in terms of how we teach and the type of feedback we give and what we demonstrate, what we value through our feedback and what we are talking to students about.
Thank you. Great talk. Thank you. At the beginning, you kind of talked about the role of the culture, the organization. You brought up your model, and then you noted that the individual on the side, and it's really in the eye of the beholder of whether or not psychological safety. And so it's almost made me feel that that whole left side, you could be doing everything great, and it could still be perceived as a psychologically unsafe spot. And you tied into that last question and the social belonging. Like, what is the role of directly teaching students or helping them form narratives about their experiences? About, even though Dr. Christine was, might have been a little short with me, it's because we had this patient who was, having, an exacerbation and we needed to go fast. And it wasn't about me. It was this chaotic environment, and that's the narrative that I'm taking. It's just chaos. Or I'm actually on a quest right now, and I'm learning things, and I'm trying to figure out who I am. And I now know I don't want to be like Dr. Christine, which is not true. He's a great guy. But I'm just kind of curious. It's just like it seems like a lot of pressure on us as individuals in this larger organization that drives the culture to create a psychological safe space, when it seems that it could all just be in the eye of the beholder. Like, yeah, and it gets to the kind of the mindset as well.
Yeah, so I have sort of two thoughts about that. One, I think it's true to some extent, like I said, as well, like it's not going to be achievable for everybody on your team, but I still really think of it as almost like universal precautions. Like it's still worth doing whatever you can do to make it a good experience for somebody. That's one. Two, I think that to the extent that those meta messages can be really transparent, and you have sort of that explicit statement about sort of like why you do what you do, or that makes it clear. Like it sort of takes away the space for a different narrative if you can be really explicit. Like, I hear a lot of times from faculty like, we can't use the Socratic method anymore. These snowflakes, I don't know, they're just like freak out and then I get a bad evaluation. And I don't think that's true that you can't use Socratic method. But I think what the difference now should be that what we say is like, again, I ask a lot of questions. It's always fine if you don't know. It's not to embarrass anybody on the team. It's really so that I know what you already know and can teach you the next thing. That framing is so different than just like repeated questioning when they've already said they don't know. I think there's also space for us to remember the initial intent of the Socratic method, which was not to help have people recall discrete amounts of information, which is how we often use it now. The intent was actually larger theoretical understandings of things. And so questions should be more open-ended, allowing for basically multiple right answers, and that allows a student to show the types of understanding that they have. Instead of like, yes, I know the three like signs of whatever, So I think there's that as well, which was not at all what you asked, but I think is just sort of like the idea of always sort of tying what you're doing to an intent of learning and support of this trainees as best you can. Let's see, I had one more piece that I thought I would say, but sorry, it left my brain.
My question is around like how much psychological safety, like our students, we have some of these structures now, they're in like stable groups their first year, they're in LICs. And so they're with us for, that continuity piece is actually now built in.
Yeah.
But like my student might have like surgery in the morning and then come to me in the afternoon. And like, how does like whatever is going on out there, like say they have a preceptor that is not creating a psychologically safe, like does that ooze over into like what I'm able to do, and how does that impact their learning? Like, are they going to be, I'm hoping I create a good environment, right? Are they going to be phenomenal internists, but horrible at like whatever other group, I guess like, what is that interplay?
I do think there probably is some bleed, just in the sense of, especially that scenario, like it is hard to fully change gears between morning and afternoon. But I still think that to the extent that they are coming to you knowing that they're going to have a reprieve from the morning's environment, has an impact. I do. And I think, again, like the more time you have relationship with that student, the better they are able to see you as a person of support, even if they're not having a good experience in other places. But this is the other thing that I think is so tricky about psychological safety in medical education, and I mean medicine in general. Like, for example, we as the physician faculty can do everything we want to do to create the perfect world. And then there's like a hostile interprofessional colleague. Maybe there's like some tension between a resident and the nursing or whatever it is. That still basically impairs their sort of overall experience in the learning environment that we had no control over. This actually happened at UW. There was a lot of problems with a specific surgical site. And when they went to find out what the problem was, it was an ARNP that had been there for 100 years. And the physicians had absolutely no power to fire her or to say, like, you can't work with students anymore. So these things happen, and it can be really hard to repair those settings. We do live in a complex, intertangled system. I still, again, like, I just think we can have control over what we can have control over, and we can create those positive connections for students that we know from all other types of research are hugely impactful in terms of somebody's ability to thrive and succeed in otherwise difficult conditions.
So thanks for a terrific talk on an important topic, Addie. I have so many thoughts and questions, but the one I wanted to ask has to do is there is basically how do we how good are we, or how much do we know about the differences in cohorts over time? Like I think about I think about when I went to medical school, where mistreatment was, there wouldn't have been anybody who would have answered no to that. But the difference was, I think that it was viewed as a normative experience. So, and if there was a silver lining to that, it was your support was in your cohort of students, right? Because we were, and everybody knew that if you rotated through that operating room with that attending, you were going to get mistreated. And, 20% of us had exactly that experience, and we knew the other places. And so I think all the things you said were true about, you'd learned nothing in that operating room, et cetera. But I don't know that people would have necessarily said, would have interpreted that as mistreatment, that it was normative enough. And so, and I think about my own children, who, if you ever sort of corrected them, would accuse you of yelling at them. It's like that. So there, I think there is for a good reason, a higher expectation over time of how we should be treated, that I think is generational. So I'm just curious, as we look at these trends and say, well, gee, we're doing better at this. Are we doing better, or are the, if maybe we are doing better, but to Jared's point, the right side, the individual perception has changed enough that we can't tell. So I'm curious, is there any empiric information about that?
I don't know of any data specifically tracking psychological safety over time for students. There was a study recently published about, it was sort of a quantitative look at the individual portion, like what it was sort of like, it impacts this, your position in the hierarchy impacts X amount. And it was kind of interesting in that way, but I don't know of any overtime data. I do think there is a huge piece of expectation, similar to me. Like, I sort of remember my surgery clerkship, and I went into it thinking like, well, it's going to be terrible. And then it's like, it was terrible. But then it was like, that's fine. I knew it was going to be terrible. And so I think their expectation, and for that reason, like you said, it was sort of, it didn't feel personal. It was just sort of like, this is the environment that I find myself in. So, I don't know. I do think there is a role of expectation and the support that you get from each other. I don't know if that really answers your question very well, but yeah, Tyra probably knows better than me.
Only because I'm working on a scoping review of medical student burnout over time, which is tangentially related. And we saw a huge decrease in emotional exhaustion, depersonalization, really stress, measures of stress in medical students immediately post-pandemic, whereas we saw huge increases in those for everybody else post-pandemic. And when you look more at the qualitative data, it's all around, like, of course, medical students were taken out of the learning environment and they had much less to do. And their burnout was much, much lower. However, their uncertainty about the future and their loneliness skyrocketed compared to everybody else's. And actually their self-compassion decreased. And so I think there's something to what you're saying, is that we could optimize the learning environment perfectly. And if we don't also teach our learners how to hold uncertainty, for example, or, feel an uncomfortable emotion, then all of it's going to fall flat. And what Addie keeps saying is, like, there's this learner perception side and the environment. And if we forget either one of those, the other one can't function. And so I think we should focus on how our learners make their narratives and make meaning out of their experience, because there could be that one toxic person and all this good work you've done is for nothing. or, you know, you could say, have your medical student in Better Together, and that one toxic person doesn't have to mean that their learning environment is toxic. So I think it's just another plug for both and. It's definitely both and, the learner and the environment.
And this is the least favorite part of my job, where I have to wrap up a really engaging discussion when there's still questions going on. So for the sake of time, I do have to do that. Dr. McClintock, thank you for bringing really all this evidence and your expertise on psychological safety to us. And we'll wrap up Grand Rounds now. So thanks everyone for joining.